Microscopic polyangiitis. Microscopic polyangiitis is a rare autoimmune small vessel vasculitis that causes inflammation and necrosis of capillaries, venules, and arterioles. It commonly affects the kidneys, lungs, and skin, often leading to multi-organ dysfunction. Unlike granulomatosis with polyangiitis, microscopic polyangiitis does not cause granuloma formation. Causes. The exact cause is unknown, but microscopic polyangiitis is associated with autoimmune mechanisms. Most patients are positive for anti-neutrophil cytoplasmic antibodies, ANCA, typically perinuclear ANCA, p-ANCA, directed against myeloperoxidase, MPO. Less commonly, patients may be cytoplasmic ANCA positive, c-ANCA, against proteinase 3. Peak incidence. Most commonly affects adults aged 50 to 60 years old. Affects males and females equally. Pathophysiology. Autoantibody-mediated inflammation leads to fibrinoid necrosis of small vessels. No granulomatous inflammation, which distinguishes it from GPA. Organ damage results from immune complex deposition and vascular compromise. Symptoms. Symptoms depend on the organ affected. Pulmonary involvement, cough, dyspnea, and hemoptysis due to pulmonary capillaritis or alveolar hemorrhage. Renal involvement, hematuria, proteinuria, and rapidly progressive glomerulonephritis, RPGN. Skin, palpable purpura, often on the lower limbs. Neurological, mononeuritis multiplex or peripheral neuropathy, for example, numbness, weakness, tingling. Systemic, fever, weight loss, and fatigue. Signs. Skin, non-blanching palpable purpura and ulcers. Renal, signs of acute kidney injury, for example, reduced urine output and edema. Lungs, crackles and auscultation if alveolar hemorrhage is present. Peripheral nerves, asymmetrical sensory or motor deficits. Investigations. Blood tests. ANCA testing. p-ANCA anti-MPO. This is positive in approximately 70% of cases. c-ANCA anti-PR3. This may be positive in a minority. Elevated inflammatory markers ESR and CRP. Renal function tests show raised urea and creatinine if renal involvement is present. Urinalysis, proteinuria and hematuria, and may show red cell casts in glomerulonephritis. Imaging. Chest X-ray. This may show bilateral infiltrates or ground glass changes suggestive of alveolar hemorrhage. High-resolution CT. Ground glass opacities or pulmonary nodules. Biopsy. This is gold standard. Renal or skin biopsy confirms diagnosis. This shows necrotizing vasculitis with no granulomas, supporting microscopic polyangiitis over GPA. Complications. End-stage renal failure, diffuse alveolar hemorrhage, peripheral neuropathy, and infection due to immunosuppression. Management. The goal of treatment is to induce and maintain remission while preventing organ damage. Induction therapy. High-dose corticosteroids, for example prednisolone. Cyclophosphamide or rituximab is preferred in some guidelines. Adjunctive therapies. Plasma exchange, plasmapheresis, may be considered in life-threatening pulmonary hemorrhage, severe renal involvement, and rapidly progressive disease. Maintenance therapy. Once remission is achieved, switch to azathioprine, methotrexate, or mycophenolate mofetil. Taper corticosteroids gradually. Supportive care. Monitor renal and lung function regularly. Pneumocystitis jirovecii pneumonia, PJP, prophylaxis may be considered. That was the full video, and there's hundreds more like it waiting for you at finalmed.co.uk. Get over 9,000 UKMLA exam questions, hundreds of animated videos, and our trusted textbook all in one platform designed to make your revision faster, clearer, and exam focused. Start your free 7-day trial today